Hello, my name is Doreen Lilly. I'll be presenting to you today a PD catheter care plan video. In this care plan video, I'll be talking about the coiled neck Tenkoff PD catheter, the rationale for choosing the specific catheter, along with the advantages and disadvantages of using the coiled neck Tenkoff catheter. I will also talk about the pre-insertion preparation, the pre and post operative care, as well as materials used to make this catheter and the patient's perspective of the procedure. The coiled neck Tenkoff catheter provides less movement in the abdominal wall location. It supports healing and less trauma to the exit site. This catheter is one of the most widely used due to easy insertion and rapid inflow and outflow. The coiled neck Tenkoff catheter has two Dacron cuffs, which fixes the catheter into position, allowing tissue growth, thus minimizing leakage of dialysate and preventing bacteria from entering. This is an illustration of a cross section of the abdomen showing you the insertion of the catheter in the peritoneum. The coiled neck Tenkoff catheter is made of silicone or polyurethane material. Polyurethane material allows for smaller tubing and larger dacrons, which can allow for better flow. The advantages of having the coiled neck Tenkoff catheter is designed to reduce complications such as infections and illnesses. This catheter will last for many years after insertion. Coiled neck Tenkoff catheters have a barium impregnated radiopaque stripe throughout the catheter length, which can assist in radiologic visualization. One of the disadvantages is it is more difficult to be removed. Surgery is required to remove the coiled neck Tenkoff catheter, requiring sedation. Along with surgery, it can cause pain and discomfort after the insertion procedure. The catheter can easily obstruct any waste or discharge from the kidney, which can quickly cause a buildup in the tube. Pre insertion preparation of the patient is to complete preoperative assessment, check for existing hernias and repair before surgery, determine site while patient is in a relaxing sitting or standing position, avoid skin folds and abdominal scars. Site should be easily accessible for exit site care. Mark site clearly with a permanent skin marker. Consider patient's activity level before insertion. This is an illustration of the insertion of the CAPD catheter using the band-down method. Measurement of the depth of the abdominal wall is taken. An introducer needle is implanted toward the pelvis. The dilator with a sheath is inserted over the guide wire. The Tenkoff catheter is threaded onto a stiffening stylet into the deep pelvis while the sheath is splitting. Post-operative care of the patient. Prevent trauma to exit site and traction to the cuffs by immobilization. We immobilize the site by using tape and ensure that it is secure. Minimize intra-abdominal pressure to prevent leakage. Flush catheter with 500 to 1500 ml of PD fluid to check for patency. Exit site should be undisturbed for 7 to 10 days following insertion. Minimize any bacterial colonization of the exit and tunnel during early healing. Keep site clear of exudate by using aseptic technique with dressing change 2 to 3 weeks after insertion. Long-term care of the exit site. Harsh solution should be avoided. Ensure exit site is cleansed and thoroughly dried before covering with bandage. A waterproof or occlusive dressing should be applied before swimming and bathing. Do not immerse exit site in water. example jacuzzis and hot tubs, without a waterproof dressing. Also, be aware that diving should be avoided as this will put tension on the catheter at the exit site. The patient's perspective. The patient should receive the education and gain knowledge about the insertion procedure of the PD catheter. This will allow better reception of the procedure and the effects on body image. The care team will give psychological support to the patient and enforce the benefits and positive outcome of this procedure, which will allow a better quality of life to the patient. Thank you.